Welcome back. This is the last video for Chapter 6, and in this particular discussion we're going to cover both plasma cell disorders and Langerhans cell histiocytosis. Now, plasma cell disorders are also called plasma cell dyscrasia, and dyscrasia basically means disorder. Plasma cell disorders are a broad spectrum of disorders. The prototypical example is multiple myeloma, and so we'll start with multiple myeloma. Multiple myeloma is a malignant proliferation of plasma cells. It's the most common primary malignancy of bone. Overall, the most common malignancy to involve bone is actually metastatic carcinoma, but notice here that we're saying the most common primary malignancy of bone. One of the important features that drives the production of these plasma cells is serum IL-6. IL-6 is often elevated in these patients, and IL-6 is an important growth factor for plasma cells. And because it's an opportunity for examiners to tie in immunology with pathology, IL-6 often shows up on exams as well, especially in this context. Now, when we have a neoplastic proliferation of plasma cells, the clinical problems are all going to be based on what the plasma cells are actually producing. For example, the plasma cells have the ability to produce osteoclast activating factor. Osteoclast activating factor. And when it produces osteoclast activating factor, the osteoclast will get activated. Of course, the osteoclasts, they eat away at bone, and so that'll result in punched out lesions that will be seen on X-ray, particularly in the vertebra and the skull. Now, those punched out lesions will result in bone pain, and that will also produce hypercalcemia, because as you punch out the bone, calcium will be pushed into the serum. And there's also going to be an increased risk of fracture, because when you punch out the bone, that's going to weaken the bone, increasing the risk for fracture. So I would probably summarize this slide by just remembering that the plasma cells produce osteoclast activating factor, which, by the way, if you go back to biochemistry, activates the osteoclast via the rank receptor, and that then subsequently is going to create all of the problems of bone that we are so classically used to identifying. For example, this is an X-ray, and we can clearly see that there are these circular regions of punched out bone on this X-ray, highly associated with multiple myeloma. Now, in addition, the plasma cells of multiple myeloma will produce immunoglobulin, and when they first produce immunoglobulin, there will be an elevated serum protein. When you have a patient that has an increased serum protein and you can't determine the cause, one ancillary test that's particularly useful is called a serum protein electrophoresis, or an SPEP, serum protein electrophoresis. Now, the way this works is that if this is the gel, as you run the serum on a gel, you'll develop certain bands. For example, the most abundant protein in the blood is albumin, so there'll be an albumin band. There's an alpha-1 band, an alpha-2 band, a beta band, and also a gamma band. Now, this gamma peak here, this represents the gamma globulins, and this peak is usually wide, and it's not as high as the albumin peak. So this is a normal serum protein electrophoresis, roughly. And of course, the gamma globulins include IgG and IgA and IgE, etc., IgM, etc. Now, in a patient who has a multiple myeloma, they have a tumor of plasma cells, and the plasma cells are going to overproduce immunoglobulin, so that when you run this serum protein electrophoresis, you're going to see a very sharp spike in the gamma region. And this sharp spike, this is called an M spike. Now, important to note that the M spike indicates monoclonal immunoglobulin. M spike does not mean that it's IgM. It just means that you have a monoclonal immunoglobulin. Notice that this band is tight and it's very high. Tight in the sense that it's very narrow, but it's also very high. So this is called an M spike, and again, it indicates monoclonal immunoglobulin. Now, it so happens that when you think about multiple myeloma, the neoplastic cells produce immunoglobulin, and that immunoglobulin would be seen as an M spike on the SPEP. However, it's most commonly IgG or IgA. So that an M spike in multiple myeloma is usually IgG, but can be IgA. One complication of having a neoplastic proliferation of monoclonal plasma cells is that those monoclonal plasma cells are all going to produce the exact same antibody. Now, remember that the goal of the body is to have 1 million different plasma cells that produce 1 million different antibodies. However, if you have one plasma cell that's producing 1,000,000 antibodies, but every antibody recognizes the same antigen, you're going to lose antigenic diversity. And so patients with multiple myeloma, they lose antigenic diversity because they only have one antibody produced from one mother cell, and that's going to result in an increased risk for infection. Infection, in fact, is the most common cause of death in multiple myeloma. Now, another consequence of having too much protein within the blood is that it's going to interfere with the charge between the red blood cells, so that there will be a decreased charge between the red blood cells. And when there's a decreased charge between the red blood cells, when you have a blood smear, instead of the red blood cells distributing themselves equally across the smear, they're going to start piling up on each other like poker chips. And so this is called rouleau formation. And that's, again, a sign of the high serum immunoglobulin in patients with multiple myeloma. Another consequence of multiple myeloma is that the plasma cells, the malignant plasma cells, are going to overproduce light chain. Go back and remind yourself from normal immunology that when immunoglobulin is formed, it's actually formed by both heavy chain and light chain. And it's the heavy chain and light chain that join together to form the immunoglobulin. Normally, the plasma cell would produce an equal amount of heavy chain and an equal amount of light chain so that it can then produce immunoglobulin. However, when you have a multiple myeloma, there's overproduction of light chain often. And the overproduction of light chain results in free light chain that circulates in the serum and eventually deposits in tissues. And when it deposits in tissues, that forms an amyloid called AL amyloid. And remember that AL amyloid is also known as primary amyloidosis, so that these patients can develop amyloidosis. The light chain can also get excreted in the urine, which would then result in proteinuria, and when those proteins are excreted in the urine, i.e. the light chains, that's called Bence-Jones proteins. At the same time, the light chain can deposit in the kidney tubules, which could then damage the kidney, resulting in renal failure, and that's called myeloma kidney. So basically, if we wanted to summarize the problem with the light chain, what we could say is that the light chain goes into the blood and deposits as amyloid, goes into the urine and comes out as Bence-Jones proteins, and deposits in the kidney itself, which results in renal failure. And that is an overall summary of multiple myeloma. And again, the way I think about it is that you've got a neoplastic proliferation of plasma cells, and the plasma cells are overproducing various substances which then give clinical findings. Substance number one, osteoclast activating factor. An osteoclast activating factor will then punch out the bone marrow, giving you bone pain and increased risk for fracture, will also create hypercalcemia. Similarly, the plasma cells are going to produce immunoglobulin, giving you a high serum protein with a M spike on serum protein electrophoresis. And also, you're going to lack antigenic diversity because you've only got one cell type that's making all of the immunoglobulin, which is then going to result in an increased risk for infection, which is the most common cause of death in multiple myeloma. And the third complication is that you're going to overproduce light chain, and the overproduced light chain will go into the blood, deposit in tissue as amyloid, go into the urine, come out as Bence-Jones proteins, and can possibly deposit in the kidneys, resulting in myeloma kidney. So I think that's a very easy and straightforward summary for multiple myeloma. Now let's pretend that you see a patient in your clinic, and this patient has a high serum protein. Of course, when they have a high serum protein, you need to explain the cause, and so you do an SPEP, and when you do the SPEP, you clearly see that there is a M spike. Now, once you see an M spike, you start thinking about the possibility of multiple myeloma. So in this patient, you then ask the question, what other findings are there? So you begin to look for lytic lesions, but you don't find them. You look for hypercalcemia, but you don't find it. You look for amyloid, you don't find it. You look for Bence-Jones proteinuria, you don't find it. So when you have an isolated M spike with none of the other findings of multiple myeloma, that is called a monoclonal gammopathy, problem with the gamma globulins, of undetermined significance, i.e. MGUS. And so this is an important plasma cell dyscrasia to be aware of. This is common in the elderly. 5% of patients over the age of 70 have MGUS, and 1% of those patients each year will go on to develop multiple myeloma. So it's almost like a dysplasia or like a pre-myeloma state. Another important disorder to consider in this particular discussion, mostly for the purposes of compare and contrasting, is Waldenstrom's macroglobulinemia. Now this is a lymphoma, but it produces monoclonal IgM. IgM is a pentamer. It's a big antibody, and that's why we call this disease macroglobulinemia. It's a big globulin, i.e. IgM. Now, because this is a lymphoma, the patients are going to present with generalized lymphadenopathy. That's what lymphomas do. They go to the lymph node. Lytic bone lesions will be absent. There will be an increased serum protein with an M spike, but instead of being due to IgG or IgA, it'll be due to IgM. And again, this is Waldenstrom's macroglobulinemia, and that's what we would expect to see, IgM. Now, that IgM is a very big molecule, and it increases the viscosity of the blood. And when it increases the viscosity of the blood, there's going to be a risk for retinal hemorrhage or stroke, and that would be a consequence of this hyperviscosity. At the same time, there's going to be an increased risk of bleeding, and that's because the hyperviscosity leads to defective platelet aggregation, and if the platelets can't aggregate properly, there could be an increased risk of bleeding. When patients have acute complications in Waldenstrom's macroglobulinemia, you can treat them with plasmapheresis. This is basically removal of the patient's blood, and then once you've removed it, you use a machine to pull out the IgM, and when you pull out the IgM, you'll obviously decrease the risk of the acute complications. So these are a few of the plasma cell dyscrasias, and again, we don't want to go into extensive detail here, but I think you understand the prototypical diseases, and that's what's key to know for basic clinical practice as well as examinations. The next and final section of Chapter 6 is Langerhans cell histiocytosis. Langerhans cells are specialized dendritic cells found in the skin. They're derived from bone marrow monocytes, and they present antigen to naive T cells. A tumor of Langerhans cells is called Langerhans cell histiocytosis. This is a neoplastic proliferation. Characteristic of these cells is that the cells often have Burbeck or tennis racket granules, which can be seen on EM, and also the cells are classically CD1A positive and S100 positive by immunohistochemistry. So here's a tennis racket granule, and this obviously is the tennis racket from the 1960s. This is not what tennis rackets look like anymore. However, it is a very high yield image to be familiar with. So this is a Burbeck granule, and it's characteristic of a Langerhans cell. Now, when you think about Langerhans cell histiocytosis, it's a relatively complicated discussion because it's hard to remember these, particularly because you'll never probably see them. So there's 3 subtypes, and I have some basic principles that I like to remind students of when I talk about these. Number 1, if the disease is named after someone, the proliferation is usually malignant. All right? If the disease has people's names in it, then it's malignant. And malignant proliferations usually involve the skin. And if there's 2 people's name, it'll usually be seen in children less than 2. And if there's 3 people's name, it'll be seen in children greater than the age of 3, for example. Now, again, these are just silly mnemonics to help us to remember these diseases, but as I walk you through these diseases, you'll see that it'll become somewhat helpful. For example, the first of these is Lederer-Seaway disease. Again, two people's names in the disease, and so it's malignant. And if it's malignant, you're classically going to see a skin rash. And because it's 2 people's names, it'll be in infants less than 2 years of age. So let's read together. Classic presentation is skin rash and cystic skeletal defects in an infant. Multiple organs may be involved, and this is rapidly fatal. Eosinophilic granuloma does not have a name in the disease name, and so therefore it's a benign proliferation. Again, that's my little way of remembering it. The classic presentation is a pathologic fracture because it usually involves bone, usually presents in an adolescent. The skin is not involved. It's benign, so the skin would not be involved. And the biopsy is going to show Langerhans cells with abundant eosinophils, and that's why it's called eosinophilic granuloma. It's important to be familiar with this disorder because especially on examinations and even in the clinics, if you've got a patient with a pathologic fracture that's an adolescent, for example, they're playing basketball and then they fracture a bone, you would start thinking about osteosarcoma. So it's important to have eosinophilic granuloma on your differential as well. The final histiocytosis that we want to talk about is Hans-Schüller-Christian disease. Again, this has 3 names in it, so we're going to think about it as malignant. Because it's malignant, it's going to involve the skin, giving you a scalp rash, and there can also be lytic skull defects. The patients classically also have diabetes insipidus and exophthalmos, and it's usually seen in a child, classically greater than the age of 3. So these are some silly ways of remembering Langerhans cell histiocytosis. And of course, they're not very common. They're somewhat difficult to remember, and some people might even say they're quote-unquote low yield. But anyway, I hope that that's helpful to you in gaining just a very simple understanding of these disorders. And that closes off Chapter 6.